Okay, welcome everyone. It is the top of the hour, so we're going to go ahead and get started with our presentation today. This is Pneumonia Clinical Guidelines and Prevention by Stevi. She is a pharmacist that works out of the Wyoming office at Mountain Pacific, and we are pleased that she was able to do such a quick review to the new guidelines that just came out a few days ago. So we're looking forward to hearing her information. A couple of little housekeeping items. Number one, we do want this to be an all teach, all learn webinar. So feel free to use both the chat liberally, or if you have specific questions that you would like to have opened to Stevi, feel free to chat those in the Q&A as well. Either one will work. So we don't want to impede any interaction between the participants here. So with no further ado, I will, a couple of other just highlights that I forgot. At the end of the presentation today, you will see a survey, and that really helps us, your answers to that help us delineate further education materials and what worked and what didn't work for this webinar, so please fill that out. And Stevi does have just a titch bit of laryngitis. So that just started today, of course, with a presentation. So if you do have trouble hearing her, chat something in and we will address, we'll see what we can do on our end. So take it away, Stevi.
Awesome. Thank you, Amber. I appreciate that introduction. So like she said, if you have a hard time hearing me, please let me know, and I will try to make sure I'm speaking into my microphone. So for today, we are going to talk about the 2019 Community-Acquired Pneumonia, or CAP guidelines. They came out last Tuesday, so they are 8 days new. We're going to highlight the changes from the 2007 guidelines, and then we're going to talk about the immunogenicity of the pneumococcal vaccine. We're going to talk about adult immunization guidelines for pneumococcal vaccine. And then we're going to review administration and some patient education points when we're giving those vaccinations. Like I said, the guidelines are here. They came out again from the American Thoracic Society and the Infectious Disease Society of America. We've included a link there for where you can access those. They are available free online at this time. You can print one copy. If you need further copies, you'll have to contact the publisher to request permission for that, but they are readily available. And you might notice that the new guidelines have a new format. So they have moved toward this PICO framework, where they have taken clinical questions, about 16 of them, and framed the guidelines around those questions using grade evaluation. So that's the grading of recommendations, assessment, development, and evaluation. You'll see the evidence has a rating of high, moderate, low, or very low. And then based on the quality of evidence, they will assign their recommendation either a strong or a conditional recommendation. So sometimes in the grade framework, something that has low or very low quality of evidence can still be a strong recommendation. So just be aware of that, and that is mostly used in times where the consequences of that recommendation are high, where they prevent harm or save life. So when you're reading these, you'll see the statements, "we recommend," which indicates a strong recommendation, or a conditional recommendation where you would see "we suggest," and then you can look at parentheses at the end and you'll see strong recommendation, conditional, with additional information. And they do have a an appendix available online where they provide that evidence to you. So the guideline scope, they're going to address the clinical entity of pneumonia that is acquired outside of the hospital setting, so that community-acquired pneumonia. And they did want to focus on at the time of clinical diagnosis, and they do still recommend that diagnosis be signs and symptoms of pneumonia with radiographic confirmation. Most of us know signs and symptoms of pneumonia can be easily interpreted as many other clinical conditions, and so they really encourage that radiographic confirmation whenever possible, with the caveat that they're aware that that's not always possible in a community setting. These guidelines do only apply to patients that have resided in the United States and they have not recently completed any foreign travel, especially to regions that have an emerging respiratory pathogen. So the pathogens of pneumonia are changing and evolving, particularly with vaccination. And so this is something to be aware of and should be on your checklist. If a patient's presenting, you will need to know whether or not they've traveled recently. And then this doesn't apply to patients who have an immunocompromising condition. So that would be things like an inherited or acquired immunodeficiency, drug-induced neutropenia, people who are actively receiving chemotherapy, patients with HIV that have a suppressed CD4 count, people who have had a solid organ or bone marrow transplant that are receiving those immunosuppressant medications. So those folks that typically we have to be a little bit more concerned about would require extra evaluation outside the scope of this guideline. One thing that has not changed from the 2007 to 2009 CAP guidelines is the severity criteria. The Infectious Disease Society and the American Thoracic Society still encourage this validation criteria for severity to be used. The patient will need to have 3 or more minor criteria or 1 major criterion to have severe pneumonia. This can be used as an indicator of whether or not a patient should be hospitalized, whether or not they need to be in the ICU, and it also helps guide our therapy. These criteria alone should not guide whether or not you should admit a patient to the hospital with pneumonia. You have to look at comorbidities and the overall health of the patient as well. So when we break down the differences between the 2019 and 2007 guidelines, there are several things that have changed. The recommendation for sputum culture has changed pretty drastically. It was primarily recommended in the past in patients with severe disease. Now we really want to focus on patients who have severe disease or that are hospitalized if we are treating for MRSA or Pseudomonas. It's difficult to get a good sputum culture. Even patients who feel like they have a productive cough, that's not always a valid sputum culture. We want sputum that is from deep within the lungs. There can be a lot of contamination with pathogens because our throat is normally colonized with a lot of different bacteria. So this is not always clinically useful, particularly in community-acquired pneumonia, and so they've recognized that. However, if you're concerned the patient has MRSA or Pseudomonas, we do want to try to culture that out. And so for those patients, particularly if they've had a history, you're going to want to try. Blood culture is very similar. We used to just recommend it in severe disease. Now again, we're looking at inpatients who are empirically treated for MRSA or Pseudomonas aeruginosa. So those patients that are inpatient, that we're empirically treating, they have to have severe illness, and then they also have to have a history or exposure to MRSA or Pseudomonas. There is still a conditional recommendation for macrolide monotherapy. This previously was strong recommendation in outpatient. We all know that resistance patterns are changing for our macrolides. And so you do need to know what the level of resistance is for your community. If it is above 25% or above the threshold set by your guiding facility, you cannot use macrolide monotherapy. It is not always a successful treatment. There's been a lot of discussion about procalcitonin in pneumonia. Procalcitonin can be produced when cells are destroyed during times of infection. This was not something that was well covered in the 2007 guidelines. At this time, they do not recommend that we use procalcitonin to determine the need for initial antibacterial therapy. They have a lot of good evidence for that. It includes things like this test is expensive. It's not always definitive. The results are mixed. So until we have more evidence letting us know the value of procalcitonin in clinical judgment, hold off on that. Like I said, it is an expensive test and it adds to the cost of care without a lot of perceived benefit. Another thing that wasn't covered in the 2007 guidelines was the use of corticosteroids. They did weigh in this year saying they do not recommend the use of corticosteroids in bacterial pneumonia. However, you may consider that with refractory septic shock. If a patient is that ill, chances are high that we are doing a lot of interventions anyway, and so if that's part of your protocol for septic shock, continue using it. That's a life-saving measure, but those are the patients that we should reserve steroids for. They have officially abandoned the healthcare-associated pneumonia category. The emphasis for treatment is moving much more toward knowledge of local epidemiology and then valid risks for the need for coverage for MRSA or Pseudomonas. And we can get into that a little later and talk about what those risk factors will be. But for the most part, you're going to want to use your local antibiogram to determine what agents are resistant, what is most useful, and also hopefully you'll have some lab information as well to let you know what the common infection agents are. And then we've got an increased emphasis on de-escalation of treatment if those cultures are negative. We're all about antibiotic resistance, avoidance, using our antibiotics safely and appropriately. When we throw these additional antibiotics on patients that don't need them, there can be serious consequences. We're seeing a rise of C. diff. We know there are increasing resistance patterns. So whenever possible, we should use the most narrow spectrum of coverage that we can. And there has been a change to the standard empiric therapy for severe CAP. In 2007, a beta-lactam and a macrolide and a beta-lactam and a fluoroquinolone combination were given equal weight. There's more evidence at this time that a beta-lactam plus a macrolide combination has favorable results. It both has good outcomes for the patient in treatment of their pneumonia, and it also has a different side effect profile. Fluoroquinolones carry an increased risk of tendinitis, tendon rupture, and also carry a higher risk of C. diff than macrolide. And so those are things to consider with our patient population, particularly the elderly. And then there's been more discussion around the routine use of a follow-up chest x-ray to make sure that the infection has cleared. This was not addressed in the 2007 guidelines. And they do come out with recommendations this year saying we don't need to obtain these. That would be additional testing for a patient, additional exposure to x-ray that they don't need. However, this is a really good time to screen patients to see whether or not they might be eligible for a lung cancer screening. And those patients obviously would need to go on once they're well and perform that screening as clinically indicated. So this chart outlines the empiric treatment that we can use in an outpatient setting. So for folks that are not ill enough to be in the hospital, people that do not have comorbidities and don't have any risk factors for MRSA or Pseudomonas can be given amoxicillin 1 gram 3 times a day, or doxycycline 100 milligrams twice a day, or azithromycin 500. They want a traditional Z-Pack, so 500 milligrams on day 1, and then 250 days 2 through 5. If local resistance is below that 25% threshold. Any of those are reasonable options. For most patients, amoxicillin will be the most affordable option. Insurance coverage varies, but if you're paying out of pocket, that one is the one that is most affordable. Doxycycline is our most expensive on that list, with azithromycin coming in the middle. It's important to know that there's no pharmacodynamic difference, pharmacokinetic difference between azithromycin in a Z-Pack or in the tri-pack, which is 500 milligrams for 3 days. Those can be used interchangeably for most patients that have non-severe pneumonia. Patients that do have comorbidities, that would include folks that have chronic heart, liver, lung, or renal disease, people with diabetes, people that have an alcohol use disorder, have an active malignancy, or have asplenia. They lack a spleen, either functionally or anatomically. They require combination therapy. So that's when we bust out our augmentin with amoxicillin clavulanate or cephalosporin and a macrolide or doxy, or monotherapy with a respiratory fluoroquinolone. So that would be Levaquin, 700 milligrams daily, moxifloxacin, 400 milligrams daily, usually for 7 to 10 days. I would go with whatever is easiest for patient. If you're worried about compliance, they're not able to take multiple pills every day, that's when you could go to that respiratory fluoroquinolone. They are more expensive medications, and they do have that higher side effect profile. So things to consider. I just wanted to point out while we go through this, none of these doses have been adjusted for renal or liver considerations. So if you have a patient that has renal insufficiency, renal failure, liver failure, you'll want to work with pharmacy or your drug reference to make sure you're adjusting those for the patient, because that is an important part of this, and these are not renally adjusted. So that was our outpatient treatment. Now moving toward inpatient. Our standard regimen will be a combination therapy of beta-lactam and macrolide or respiratory fluoroquinolone. Those are for patients that just have no other considerations. If they've got prior respiratory isolation of MRSA, we're going to add that MRSA coverage, and we're going to try to obtain a culture or do a nasal PCR. If that comes back negative, we can then de-escalate, or we'll get confirmation that, yes, this is still an MRSA concern, and we can continue with that empiric therapy. Same situation with Pseudomonas. So if we're looking to add MRSA coverage, that's typically going to be like a vancomycin or a linezolid. If we're looking for Pseudomonas coverage, we're talking about peptazo, ceftazine, imipenem. Those are all appropriate. Whatever your local guidelines are for how you treat MRSA or Pseudomonas, that is the coverage you're going to add and wrap around here. No need to deviate from your local formulary. And this continues for a non-severe patient throughout. For the most part, if we have concerns about these resistant organisms, we're going to culture. We don't need to add on that therapy. In patients that have been recently hospitalized, received parenteral antibiotics, those folks that traditionally would have fallen into those hospital-acquired, hospital-associated pneumonia, we no longer will double cover them. We're going to wait to see the results of our rapid nasal PCR or a culture if possible. So with severe patients, things change a little bit. We're still looking at, for standard regimen, we're using a beta-lactam and a macrolide. But if they're severely ill and we're looking to do a respiratory fluoroquinolone, we still want to double cover them. So we still want a beta-lactam and a respiratory fluoroquinolone. If a severely ill patient in the hospital has a prior isolate of MRSA or Pseudomonas, now we are going to add coverage. The risk of dying from those in severe illness outweighs the risk of unnecessary antibiotics, and so that's why the switch. But that is just for severely ill patients based on that criteria from the 2007 guidelines. And you'll see that go all the way down. We're still going to culture. We're still going to look to de-escalate based on confirmation, but this is the time where it's all right to add on those extra therapies. So that is our brief, and it is very brief overview of the new CAP guidelines. We'll pause for just a minute to see if anyone has questions. You can either submit your questions in the Q&A portion of your Zoom, or you can type them into chat. They'll reach us either way. And that can continue throughout the call today. So if you have any questions, jot them down, or you can email us after the fact. With that, we're going to talk about pneumococcal vaccination. One of the great things that has happened in healthcare in the last 100 years is that we have made substantial progress on the understanding of pneumococcal immunobiology and how to prevent invasive pneumococcal disease and pneumococcal pneumonia. Typically, in the past, pneumonia, the pathogen of priority was Streptococcus pneumonia. It is an endemic global pathogen. It causes a wide range of clinical diseases in both children and adults. We see pneumonia, but we also see otitis, sinusitis. We can see invasive pneumococcal, which we'll talk about here in a moment. So this is a pathogen of high concern, hence the need for vaccine. Since we're going to talk about vaccines, I wanted to give just a quick review of how our immune system works and how vaccines play into that. So when we talk about active immunity, that is where our body recognizes a pathogen, an antigen, a virus, and it stimulates an immune response. So this is an antigen-specific process. So our body identifies this foreign body, develops antigens and antibodies, and it activates cellular immunity. This process typically happens when we contract a disease and get sick, and then that piece lasts forever. We activate our memory B cells that produce the antigen, and then when there's re-exposure, these cells recognize it rapidly, they replicate, they produce antibodies very quickly. So we have that established protection. In this disease process, while our memory B cells are producing antigens, they're also able to recruit our T lymphocytes And those cells come in and they produce cytokines and they augment that response from the B cells. And that is what creates a longer lasting response. Our B cells can get forgetful when they work by themselves, and that's why we can have waning immunity to some vaccines. But when we actually are exposed to the disease, that is when we get the long-acting, lifelong response. It typically takes several weeks, so it's not what happens in the initial outbreak, but we use that when we do vaccination. So when we vaccinate someone, we introduce antigens that then stimulate those B cells to produce an antibody and activate our cellular immunity. There are lots of different kinds of vaccines. We typically break them down into two categories to begin with. We have live vaccines, where we produce a modified disease-producing vaccine or bacteria, where it still structurally is similar to the initial organism, so it produces that response, but it does not cause disease. They are able to replicate in the body, so that is different than inactivated vaccines. And our live vaccines include things like measles, mumps, rubella, varicella, zoster, yellow fever, rotavirus, oral polio. All of those are active vaccines. Typically, those vaccines are able to produce a response in the first dose. We repeat doses of those, like particularly MMR. We repeat the dose a handful of times because we're looking for the small percentage of people who won't respond to the very first vaccine. So we want to give their body a chance to cover them with subsequent doses. Live vaccines do tend to cause more serious reactions than inactivated vaccines, so that is a consideration. And because it does contain a pathogen that is able to replicate, the risk versus benefit for certain populations results in them not being able to receive live vaccines. So pregnant women, people who are severely immunocompromised, they are not good candidates for live vaccines. And then we have inactivated vaccines. There are many forms of inactivated vaccines. There are whole vaccines, fractional, polysaccharide-based. That's what we're going to talk about today. There are toxoid vaccines, and then there are recombinant. So when we look at these, the live vaccine more closely resembles the innate response we would get to an actual infection. When we use an inactivated vaccine, the immune response is mostly humoral, so mostly is those B memory cells, and those antigens diminish over time. So we revaccinate to give boosters. We're always going to give multiple doses of these. The first dose will prime the immune system, and then the second or third dose is used to produce a protective immune response. If you think about influenza vaccine in kiddos less than age 7, we give 2 doses the very first time they're vaccinated for this very reason. So with the different forms, whole vaccines would include things like, we used to have a polio vaccine that was a whole vaccine, Hep A, the rabies vaccine is a whole vaccine. We used to have whole vaccines for pertussis and typhoid, cholera. We no longer use those. Fractional vaccines would include, they include subunits of those viruses, so be like hepatitis B, influenza, and then acellular pertussis is a fractional vaccine, so is the HPV vaccine. And then the toxoid vaccine, we're pretty familiar with. The tetanus vaccine is a toxoid vaccine. And we are getting more and more recombinant vaccines as well. These are genetically engineered technology. We have new viral Hep B vaccines that are recombinant, the HPV vaccine, some of the Gardasil that's on the market is a recombinant. We have one brand of influenza that is a recombinant vaccine. So those are things that are coming about. There are advantages and disadvantages to all these different forms. But then the polysaccharide vaccine is what we're going to focus on today. So it's a unique type of inactivated vaccine where we use subunits that are composed of long chains of sugar molecules that make up the surface of the capsule around certain bacteria. So the strep pneumonia pathogen is an encapsulated bacteria. So we're trying to teach the body to recognize those different capsules. And you can have a pure polysaccharide vaccine. We've got like Pneumovax 23. One of our pneumococcal vaccines is a pure polysaccharide vaccine. And then we also have the conjugate polysaccharide vaccines. So we'll talk about those differences. When you look at the history of pneumococcal vaccine, I was a little surprised. They've been around for a very long time. In 1945, when Alexander Fleming was winning his Nobel Prize for discovering penicillin, that same year, they produced the first tetravalent polysaccharide pneumonia vaccine. Because penicillin worked so well initially for those infections, it was not viewed as the historical event that I think it is. But as people noticed that penicillin didn't work as effectively over time, we started to return to this concept of a pneumonia vaccine. That first vaccine had an 84% relative reduction for the vaccine type pneumonias, which is incredible. And in 1977, as we've developed, they came out with a 14-valent polysaccharide. So each Streptococcus pneumonia has its own little capsule. And so when we talk about the different valents, we're targeting different serotypes of pneumonia. In 83, that's when we came out with our 23-valent polysaccharide. So our Pneumovax 23 is based on that vaccine. And then in 2010, we came out with the 13-valent conjugate polysaccharide. So that's Prevnar 13. And in the middle there was a 7-valent that came out for kids as well, but it's not included because we're mostly going to focus on adults today. So why the focus on Streptococcus pneumonia? We talked earlier, there are a lot of different pathogens that can cause pneumonia, but strep pneumonia is very virulent, and we see it in a lot of cases. It's responsible for 900,000 cases of non-invasive pneumococcal disease, so that would be pneumonia, sinusitis, ear infections, and 400,000 hospitalizations, and 5 to 7% of those people affected will die. So it has a high disease burden. And then if we talk about invasive pneumococcal, so non-invasive tends to be quite a bit less deadly. Invasive pneumococcal is quite a bit more serious. So invasive pneumococcal would be things like bacteremia, empyema, meningitis, endocarditis, osteomyelitis. And strep pneumo is responsible for at least 25% of documented invasive pneumococcal disease. So it has a serious role to play in these very deadly, hard to treat, expensive conditions. They carry a lot of morbidity and mortality. For folks that get strep pneumomeningitis, there's a 10% mortality risk. If we've got bacteremia, it rises to 15%. So serious importance there. We have to worry more with patients that have asthma or COPD. If they are infected with non-invasive pneumococcal, so they get pneumonia, their risk of developing invasive pneumococcal is 2 to 6-fold higher than average patients. People who smoke, abuse alcohol or drugs also all have an increased risk of invasive pneumococcal. So we have 2 vaccines that we currently recommend in the United States to help prevent strep pneumo infection. The first one we'll talk about is Pneumovax 23. This is a purified capsular polysaccharide. We introduce those antigens to the body. It promotes opsonization and phagocytosis. So opsonization is the immune process where particles, so the antigens that are injected, are targeted for destruction, so our immune system identifies it as foreign. And then it triggers phagocytosis. So those are the cells that eat things, so phagocytosis encompasses it. If it was a live pathogen, it would prevent it from being able to replicate, and it causes destruction of the invader. This process does not trigger the T cell help or cytokine signaling. And so that's why it's not immunogenic in children less than 2, and it's less immunogenic in the elderly. After age 65, our body's ability to fight infection wanes. And so we find as people age, these vaccines do not work as well. They did test Pneumovax to see if repeated vaccination would help with antibody production. While it does cause lots of additional side effects to re-vaccinate, there is no benefit. We're not able to boost antibody titers higher than the primary immunization. So they continue to look for things that work better. And they came upon conjugated pneumococcal vaccines. So this, like Prevnar 13, is the current recommended pneumo conjugate. We inject those same polysaccharide antigens, and we inject a conjugated carrier protein, and that creates this co-stimulatory signal where we get the memory cells involved, we trigger plasma cells, and we also trigger the T cell system. So that makes it more immunogenic. We see a more rapid and robust production of antibodies. Our body remembers the pathogen longer, and we are able to get an immunogenic response in all ages, which is very important because children under the age of 2 and the elderly, it is more difficult to activate their immune system. So when we talk about the different serotypes of pneumococcal, there are 93 currently known serotypes. There's possibly more. These bacteria mutate and create new ones, but these are the ones that are covered right now. I mentioned earlier there's a PCV7 for children. That's the pneumococcal conjugate that we use in kids. And then we have PCV13, which is our conjugate for adults, and then the PPSV23. These are the different serotypes that are covered in those vaccines. And so you can see when you look at this Venn diagram here, why we layer our vaccines. Even though the PCSV23 does not produce as good of an immunoresponse as the PCV13, because it contains all those other serotypes, there is still benefit to vaccinating patients because we find that those serotypes are often implicated in invasive pneumonia. So PCSV, for at least a 5-year period, does a pretty good job of reducing a patient's risk for invasive pneumococcal. And because we're in the middle of flu season, I wanted to talk briefly about the correlation that pneumonia and influenza have with each other. These are some of our state numbers to let you know what rates we have for pneumonia admissions and readmissions. So that's the P&E. And then also influenza. That third column of flu is the flu readmission rate. But we see this can really impact our communities. We have hundreds of flu admits in our region every year, more pneumonia. And there is an important link between influenza and pneumonia. So when our body is trying to fight pneumonia, it does it 2 ways. We have innate immunity, so things our body does to fight infection all the time, and then we have our humoral or like cell immunity. That innate immunity involves things like our mucociliary cells that create an elevator in our bronchioles and our brachia and up into our trachea to sweep out irritants, pathogens, allergens, you name it, those cells are sweeping it out. When you develop influenza, that mucociliary action is diminished. And to fight strep pneumo, you have to have both the cellular recognition that the capsule is an invader, and you have to have this innate immunity. You have to have both to build a robust immunogenic response. So when we develop influenza and our innate immunity is compromised, that ability to sweep things out of our lungs, that increases our risk for bacterial pneumonia. You also can develop viral pneumonia from influenza, which causes its own complications, but just that slow down mucociliary action is why you quite often have to worry about pneumonia when folks have influenza, particularly if they have underlying health conditions where that innate immunity was not working well to begin with. And as Amber mentioned in chat, these readmits are per 1,000. So you can move the decimal over if you want to see our percentage. So like 14.9% in Alaska in 2018 for flu readmissions. So these tend to be higher than national averages in terms of just our general readmission risk. So we're going to talk about the vaccine schedule and administration, because the first thing you can do for pneumonia is prevent pneumonia, prevent invasive pneumococcal as well. So this is a copy of the table of the adult immunization schedule by age group. They have an easy read version on the CDC website now. It contains all the notes. It's very easy to figure out now who needs what. But you can see our pneumococcal is right here. We have pneumococcal conjugate about 2/3 of the way down, and pneumococcal polysaccharide. And you have all this purple, which means you have an additional risk factor. You can get it before age 65. And then it turns yellow, letting us know that all adults who meet the age criteria should receive that vaccine. We also have the adult immunization schedule by condition. So for that purple, you would then fall down here and read to see who gets it and why. PCSV 13 is Prevnar 13, and PPSV 23 is our Pneumovax 23. And you can see the yellow is there if you're immunocompromised, if you have an HIV infection CD4 count that is low, asplenia, all of those things are listed. And then it has extensive notes for you. So this is the breakdown of what's in the notes, and it walks you through who should get what. Because Prevnar 23, because Pneumovax 23 has been around longer than Prevnar 13, you might encounter patients that have received Pneumovax 23 but have not received Prevnar 13. So we have directions for that. For a patient who has never received pneumococcal, you're going to give them the PCV13 first, so that's our Prevnar. And then 1 year later, you will give the PCSV23, and then they're done until we come up with a new vaccine. If they've previously had PPSV23, but not the PCV13, they get that PCV13 at least 1 year after they're 23. And then there are some people that will get a dose prior to age of 65. If they've had PPSV23 before 65, you make sure it's been a year, give them the PCSV13, and then at least 1 more year later, give them the PPSV23. And then if they've had a PPSV at age 65, you just do that 1 dose of PCV13 and you're good to go. There are special situations where people will need to receive these before age 65. Anybody who's age 19 to 64 who has a chronic condition, so it would be like heart disease, excluding hypertension, things like congenital heart problems, severe arrhythmia, heart failure, people with lung disease, so asthma, COPD, liver disease or diabetes, people who have alcohol use disorder or smoke cigarettes should all receive a dose of PCSV in that time period, 19 to 64. I would consider in my practice including people who vape. The more we learn about vaping, the more we know it causes some damage to the lungs that is similar to damage from other pollutants. So they could be considered a candidate as well. And then people who have immunocompromising conditions, whether it's congenital or acquired, chronic renal failure, nephrotic syndrome, leukemia, lymphoma, general malignancy, anybody with cancer, you should start thinking about whether or not they need these vaccines. They will receive 1 dose of Prevnar 13, and then 8 weeks later, we vaccinate them quicker because their risk is higher. We give them the PCSV 23. They will still get an additional dose of PPSV 23 when they reach 65. It has to be at least 5 years between the 2 doses of PPSV. You also have to worry about people who have a cerebrospinal fluid leak or a cochlear implant. Again, these are folks where we worry about invasive pneumonia. So they will also receive 1 dose of Prevnar 13 followed by 1 dose of Pneumovax 23 8 weeks later. So again, that rapid immunization schedule so that we can get them covered as quickly as possible. You're going to administer both of these intramuscularly. You can also give the PPSV 23 or Prevnar, or Pneumovax, excuse me. PPSV is Pneumovax. You can give it subcutaneously as well. I find that it causes more injection site reactions. People have discomfort. So if there's some reason why they can't get it intramuscularly, you can administer it subcutaneously, but it does tend to cause more discomfort and more localized injection reactions. And the PCV13 has to be injected intramuscularly. They do recommend the deltoid for both of those. If you're giving them to children, you can give it into the anterolateral thigh. It just depends on the patient population and what they're most comfortable with. Because that Prevnar 13 has an adjuvant in it, the conjugated part of it has to be shaken to resuspend, or it won't be mixed thoroughly and the vaccine won't work as well. Pneumovax 23 does come with many adverse reactions. Injection site reactions are very common with this particular vaccine. Up to 60% of patients will report pain, soreness, or tenderness. About 20% will see swelling or a large area of redness. Sometimes that can be as large as 4 inches across, so it can be pretty good size. Sometimes if they get that swelling and induration, it can eventually cause cellulitis. It doesn't necessarily have anything to do with the technique or anything like that. It is just a risk of the vaccine. It can also cause a headache, fatigue, muscle aches, generalized weakness. These are all common. It's telling us the immune system is working, and patients can take, Tylenol, ibuprofen, those sorts of things to help manage those side effects. It does go better if you warn them in advance that they should expect those things because it is common, and especially if you get a 4-inch area of redness, that can be alarming. So letting them know what to expect and what to watch for is a very important part of vaccine strategies. For folks that receive a Pneumovax 23 before the age of 65, their second vaccine, once they turn 65, tends to have more of those injection site reactions. About 80% of patients over the age of 65 receiving that second injection will report site discomfort and or site induration greater than that 4 inches. So something to watch for. It's about 30% of the time with the greater than 4 inches induration versus 10 on the first shot. It can take up to 5 days for those side effects to resolve.
So, Stevi, this is Amber. We do have a question from Kyle. He was recently notified that the pneumococcal vaccine recommendations are changing. They no longer recommend both PCV13 and the 23, and instead recommend that it's up to the provider to decide if a patient should receive both or just one. Do you have comment if this is true?
So the current ACIP guidelines, which is what the CDC uses to build their adult immunization schedule, does still recommend both vaccines.
Okay. And then Kyla just noted that too, that the ACIP just recommended changes to PVC13 for those greater than 65. So it has not hit the CDC website yet if it's going to change. Is that correct?
It has not yet hit the CDC website. They do typically adopt ACIP recommendations though, and given the side effect profile and the potential lack of benefit because people over the age of 65 don't mount an immune response, I could see why that recommendation would be made. At this time, the adult immunization guidelines have not changed, but I would expect that to be announced. It depends on when the meetings happen and how quickly recommendations are picked up. But yes, say that's
okay.
Yep.
Hot off the presses, you heard it here first.
So, and then Prevnar 13 does have a more favorable adverse reaction profile. Only about 5% of patients will experience redness. 6% will have the swelling. Pain is still pretty common, but it is with most adult vaccines. And then they might still get a a little bit of a fever in about 2% of patients. Fatigue and headache are more common. Again, it's okay to do Tylenol, ibuprofen, those sorts of things after vaccination. If people can hold off, there's a lot of evidence in kids that taking like an ibuprofen or Tylenol before or following an immunization, it might make it less effective. There's less evidence for adults on whether or not that is the case, but I think anytime you can give your immune system a leg up, better. So if they're able to suffer through, that's better. But if it's making them really miserable, you can advise them to take an over-the-counter pain reliever. With that, we will turn it over for more questions. We do have our website up here. We do have some immunization tools and resources. If you go to mpqhs.org/QIO, under our quality improvement tools and resources, we do have immunizations listed there, and there are webinars and videos and a variety of tools and posters. So then it looks like Carla has asked if the slides will be available. They will, and we will have a recording of this presentation available on our website as well.
Just also on the recording, it does take us about a week to turn that around, so don't expect it tomorrow in your inbox. It will take about a week. Any other questions, or you feel free to, we can open it up, or you can put something in chat if you wish. I did put in a note just a few slides ago about if anybody identified changes that they need to make to their treatment protocols. We'd love to know if this was helpful to you. So we'll give it one more minute for questions. Okay then. Well, we are 3 minutes before the hour, and so I will go ahead and close the webinar and encourage everyone to fill out our evaluation that will pop up as soon as we close the webinar. Thank you very much for attending.